Welcome to Critical Care Essentials, Part 1. These are a series of lectures that you can listen to anytime you want, and if you can just listen to them in the sequence that I present and make sure you master a lesson before you move on to the next one, you will become a critical care expert. If you can break it down to one single sentence, as a critical care person, I deliver oxygen to tissues. When your blood is 100% saturated, every gram of hemoglobin will carry 1.34 ml of oxygen. If you are 90% saturated, then that becomes 90 over 100 or 0.9, and the amount of oxygen content of the blood has to be multiplied by 0.9 in order to get your oxygen content. And if it is 80% saturation, it is 0.8, etc., etc. There is a small amount of oxygen that is carried dissolved in the plasma. This oxygen in ml is your PaO2 multiplied by 0.003. As you can see by that multiplication, that this constitutes a very small percent of your blood oxygen content. In this example, if your patient's hemoglobin is 9 and the saturation is 90%, then the oxygen content in that patient's blood per deciliter is 1.34 multiplied by 9 multiplied by 90%, which is 90 over 100 or 0.9, and that equals to 10.85 ml of oxygen per deciliter of blood. For a saturation of 90%, it is most likely that the patient's PaO2 is around 60. So dissolved oxygen in this case becomes 60 into 0.003 or only 0.18 ml. This constitutes 1.6% of the patient's total oxygen content. That means in a normal state, even if your hemoglobin is 9, normally it is 15, almost 98.5% of oxygen that is carried by your blood is carried attached to hemoglobin, and only about 1.5% is actually dissolved in the plasma. Now, let's say in order to improve the oxygen content of this patient, we increase the saturation from 90% to 100%. And the PaO2, we are hyperoxygenating this person. Normal PaO2 is 90 to 100. We are making the PaO2 partial pressure of oxygen in the arterial blood to 600. Even in that case, and you don't know what you had to do to get to this 600, even in that case, the oxygen content bound to hemoglobin would be 1.34 into hemoglobin, which is 9, into 100%, which is 1, will be equal to 12.06 ml per deciliter. But the dissolved oxygen in this case will be equal to 600 into 0.003, which comes to 1.8, which is now 12.9% of the patient's total oxygen content in the arterial blood. So even in this excessive oxygenation scenario, more than 85% of the patient's oxygen content in the artery is still bound to hemoglobin. You did, though, by increasing saturation to 100% from 90% and increasing the PaO2 to 600 from 60, you did increase the oxygen content of the patient's blood from 11.03 milliliter per deciliter to 13.86 milliliter per deciliter, a 25.6% increase in the oxygen content that you got from changing the PaO2 from 60 to 600. So a 10 times increase in your partial pressure of oxygen in the arterial blood to get a 25% increase in the oxygen content. When you have an oxygen content of the blood and you multiply it by cardiac output, you get the amount of oxygen being delivered to the patient's tissues. We already know that oxygen content of the blood is equal to 1.34 into hemoglobin into saturation. And you know that 90% is 0.9, 80% is 0.8, 75% is 0.75. Now, this is in ml of oxygen per deciliter of blood. Therefore, in order to compare it to cardiac output, which is usually 5 liters per minute, you have to convert deciliters into liters, and therefore you multiply it by 10. So 1.34 into hemoglobin into saturation multiplied by 10 multiplied by the cardiac output in liters per minute is equal to your DO2. The ml of oxygen being delivered to the tissues every minute. Now we all know that cardiac output is nothing but stroke volume into heart rate. Therefore, the formula then becomes 1.34 into hemoglobin into saturation multiplied by stroke volume multiplied by heart rate multiplied by 10 mLs of oxygen being delivered to the tissues every minute is equal to your DO2. Going back to the last example, okay, let's say that in order to increase the PaO2 from 60 to 600, we had to increase the PEEP, for example, from 5 to 15. And for this, we got a 25.6% increase in our oxygen content. But because of this, let's assume that the patient's cardiac output went down from 6 liters per minute to 4 liters per minute. In that case, even though you increase the oxygen content of the blood, you might have decreased the delivery of oxygen in ml per minute to the tissues. This picture basically illustrates what is happening here. If you increase the hemoglobin or increase the PaO2, and in return you make the system so heavy that the body cannot deliver it, you can actually make things worse by affecting what really matters, which is your DO2. For all practical matters, one can easily calculate the changes to DO2 by totally disregarding the partial pressure of oxygen in the blood and the dissolved oxygen. Now let's say we have a sick patient. Patient's hemoglobin is 7, cardiac output is 4 liters per minute, saturation is 85%, and then we calculate the delivery of oxygen to be 318.92 ml per minute. Now, if I do nothing to this patient but increase their cardiac output, so hemoglobin is still 7, I have increased the cardiac output to 6 liters per minute, saturation is still 85%, I have made the DO2 478.38 mLs per minute. If I don't do that and just increase the hemoglobin to 9, so the cardiac output is still 4, saturation is 85%, the DO2 is 410.04 mLs per minute. If I choose to do none of those but increase the saturation, so hemoglobin is 7, cardiac output is still 4 liters per minute. Now I have increased the saturation to 95%. The DO2 increases to 356.44 ml per minute. And if I do all three, increase the hemoglobin to 9, increase the cardiac output to 6, increase the saturation to 95%, if I can do all of that, then they add up and my DO2 has more than doubled. So here is the problem. All of this is awesome, okay, provided that I am thinking in terms of DO2. So for example, right here, in increasing the saturation from 85 to 95%, you know that saturation can only be increased by increasing the FiO2, which in this case you can't ever go above 100%. That's the limit. And the next thing you can do to increase saturation is increase PEEP. If I increase the FiO2 and increase PEEP and make the person's saturation 95% without affecting the cardiac output, because one thing that the PEEP can do is to decrease the cardiac output. Because if I increase the saturation from 85 to 95%, approximately 10%, but because of that action, I decrease the cardiac output by 20%, my DO2 will actually decrease. And this is the whole reason why in critical care, we always ask you not to fixate on a single number. Because we know that cardiac output is stroke volume into heart rate. And the stroke volume depends on how much volume is coming into a heart chamber, how much it is contracting that volume out, and against what pressure is that volume being pushed out of the heart. And we also know that there is a right heart and that there is a left heart. Now, for example, in order to increase the saturation from 85%, which is terrible, to 92%, which is awesome for a sick patient, if you increase the PEEP from 5 to 15, what might be happening is that because of that increase in PEEP, the venous return from the body into the thorax and the right heart might decrease. So the preload decreases. That decreased preload makes sure that no matter what your contractility of the right heart, that it is not being filled with the right amount, right volume of blood. So even though the ejection fraction might be 50%, it's 50% of a lesser amount. And then when the right ventricle has to eject this blood because of the increased plateau pressure and the increased peak pressure and the increased mean pressure inside the lungs, this afterload of the right heart would increase significantly. So then whatever blood is coming on would pool into the right ventricle, and the right ventricle would then grow big and reduce the preload of the left ventricle. And therefore, if you increase your saturation from 85 to 92% by increasing the PEEP from 5 to 15, and in return your cardiac output decreases 20%, you have actually decreased your DO2 and currently are harming the patient. Everything I do it for DO2. I believe somebody has changed just one word out of that sentence and made it into a very popular song. So the next question is, wait a minute, where does blood pressure come in all of this? Because if delivery of oxygen just depends on stroke volume, heart rate, hemoglobin, and saturation, then what about blood pressure? Where does that come in? So the blood pressure does become important because it seems that tissues can regulate the amount of output, cardiac output or flow by autoregulation. But it has its limits. And it seems that if the perfusion pressure, the mean perfusion pressure, is less than 50 in a normal person, then the blood vessel has actually exceeded its limit of dilatation, and after that the flow through the tissues, the actual delivery of oxygen into the tissue, becomes dependent on the perfusion pressure. Same way, if you keep increasing your pressure, increasing the perfusion pressure, in order to regulate the blood flow, the vessels will constrict. They will become smaller and smaller and smaller in size, after which they have reached the limit of how much they can constrict. And after 150, it seems that the body loses control, and now flow depends on directly depends on pressure distending the blood vessels. The normal pressure inside a person's brain is 10, and therefore comes the advice that your mean arterial pressure should be equal to 50 plus 10 is equal to 60 millimeters of mercury, which is the minimum needed in order to perfuse organs and deliver oxygen to tissues. So once your MAP is 60, you start concentrating on the actual DO2. You start thinking DO2 provided the MAP is adequate. Now, let me tell you one thing. Nobody has done or could do a study where we let people be hypotensive. Therefore, nobody really knows what is the minimum MAP that people can tolerate. But here's the deal. If somebody's MAP is 55, okay, so let's say somebody's MAP is 55, but they are producing 40 cc's of urine. The patient is talking to me. The lactic acid is 1.5. Would I really want to make it 60 because the book says so? Because if I increase the MAP from 55 to 60, use of it using neosynephrine, if I do that and decrease the patient's cardiac output, I will be happy with MAP 60. That's fine. But it is also possible that in increasing the MAP from 55 to 60, we inadvertently, without wanting to decrease the cardiac output, therefore decrease the delivery of oxygen. We are not treating numbers, we are treating patients. And therefore, the art and craft of critical care is always to treat all of these vasopressors, the ventilator, the FiO2, the PEEP as drugs. So yes, 20 of lisinopril is awesome, 40 of lisinopril is awesome. But if my patient is not tolerating that because of hypotension, if my patient is not tolerating that because the creatinine is increasing, I will go down. I will use lisinopril 2.5 or 5. The same way, when you use FiO2, when you use PEEP, when you use the ventilator, you always treat them as drugs. You give the patient the minimum necessary. They need to be supported, and you never exceed the maximum that they can tolerate. So we know that if a patient is regularly a hypertensive patient like this one, their autoregulation might be way different. And therefore, systolic blood pressure is defined as a systolic blood pressure of less than 90 or less than 30 of the baseline systolic blood pressure of the patient. So, in some patients, if you have a MAP of 60, but they are not maintaining, they are not having urine output, you might want to make it 70. That's fine. It can go up, it can go down. But once I have reached my goal MAP, everything I do it for do two. So all my efforts now in taking care of my critically sick patient is simply to optimize oxygen delivery. Now, I know many people will immediately jump on this and blood pressures will go up and say that, oh, all studies saying maximizing oxygen delivery does not work. Yes, I agree. And therefore, I use the word optimize and not maximize. The maximum oxygen delivery that can be given in the patient's situation without harming the patient. Now remember, if you really look at ARDS-NET studies, if you really look at studies where they have actually tried to maximize DO2, not looking at those studies as abstracts, not looking at those studies on WhatsApp, not looking at those studies because your professor sent you a Facebook message. When you actually go into the depths of the belly of those studies, you will realize that in ARDS net, the people with the higher volume and higher pressures actually had better carbon dioxide, actually had better oxygen, and still died. That is because when you start thinking delivery of oxygen, you realize that making the CO2 and the oxygen normal by absolutely messing up the lung pressures or stressing the heart to do things it can't, all of those things actually harm. And therefore, we know that patients can tolerate a PaO2 less up to 55 and an oxygen saturation of 88% permissive hypoxemia, provided that that action of letting the oxygen go down actually helps with the cardiac output, helps with the lung pressures into being more protective. If you can do that, you are increasing the DO2 and you are saving the patient. Do not try to make numbers look better. Look after the patient. A normal person can extract 20 to 25% of the delivered oxygen for the personal use. The rest is reserved. And therefore, when you exert, you can increase your VO2 or utilization of oxygen up to 10 times by increasing your heart rate, by increasing your stroke volume, by increasing your oxygen saturation. But body in its maximal state is able to extract 50% of your delivery of oxygen to utilize that 50%. Okay. How do we know the VO2? Well, we already know what content of arterial oxygen in the blood is. The same way, there is a content of venous oxygen in the blood, which is 1.34 into hemoglobin into the saturation of oxygen in the vein plus the partial pressure of oxygen in the vein into 0.003, which usually, just like the artery, can be eliminated from the equation. And then we know that the utilization of oxygen, the VO2, will be cardiac output into the amount you have used, which is content of oxygen in the artery minus content of oxygen in the vein multiplied by 10 in order to convert deciliters to ml per minute. Match it to the liters per minute cardiac output we have here. And because of this, we can expand this equation and say that it is cardiac output into 1.34 into hemoglobin, saturation of oxygen in the artery minus saturation of oxygen in the vein multiplied by 10. And it is this difference which will tell you how much oxygen you are actually extracting from the body. And I'll tell you why that is important. Every day, I take my truck full of bananas to this farmer who is patiently waiting for his 75 kgs of bananas a day that he wants to sell to his customers. My truck is open and it has to go through a road. I take 20 minutes to reach the farmer's shop. And in those 20 minutes, I find that I have to drive in an area full of trees, and on those trees are monkeys, and the monkeys snap the bananas. And therefore, if I take 100 kg of bananas in my truck, by the time I have traversed the 20 minutes, I reach the farmer's market with 75 kgs of bananas, and everybody is happy. Now let's assume that one day I take my 100 kgs of bananas, and by the time I reach the farmer's market, the farmer is very angry because I have just landed there with only 50 kg of bananas. What happened? What happened? Two things can happen to make this 100 kg 50 kg. Two things can happen. Either the monkeys are very hungry or there has been an increase in the number of monkeys. So an increased demand on the bananas. And if the bananas are oxygen, an increased demand of that oxygen has taken place. Thyrotoxicosis, burns, trauma, sepsis with infection. Absolutely. The demand of the body has increased, and therefore the body has consumed more bananas than it usually does. And therefore, next day, if I have to make up to this guy, if I have to make up to this angry farmer, I better start with 125 kgs of bananas so that the monkeys can eat 50 and I still reach with 75 and everybody is happy. So increased demand, if there is increased demand, I know because I reached with less amount of bananas here. So I know that there is an increased demand and therefore I will have to increase my delivery of oxygen so that the saturation of blood that comes back is still the regular 75. Or I could just realize that the traffic was so much that instead of 20 minutes, I had taken 40 minutes to reach the shop. And therefore, the monkeys were eating just at the rate at which they eat regularly, which is 25 kgs every 20 minutes, except that I took 40 minutes to go through that road, and therefore, the monkeys ate 50 kgs, which is why I came here with 50 kgs. In either of this case, I have to increase the delivery of oxygen. I either have to increase the speed at which I drive, which is cardiac output, or I have to increase the hemoglobin and the saturation, knowing that saturation cannot increase more than 100%, knowing that hemoglobin is best at 7 because it's somebody else's hemoglobin and has been stored and therefore does not function very well. And I also know that increased hemoglobin, if I give it increased blood, is increased mass for the sick patient to circulate. My hemoglobin is 7. In dire circumstances like River et al., I can make it 9, but that's my limit. So 100% and 9. I already know that in order to increase delivery of oxygen, cardiac output from our last calculations is the best way to do that. And therefore, if I end up with 50 kgs, 50% venous saturation, I need to increase my DO2. Now you understand? So if your saturation in the blood is 100 and your saturation in the vein coming back is 75 or even 70, you are golden. But if you deliver 100% saturation, but the venous saturation comes back as 50%, you are in trouble and you better increase your DO2 or at least try to optimize it to the maximal tolerated without harming the patient. Now let's take another example. One day I had 100 kg of bananas and I reached the market to find out that 90 kg is still there. Oh my God, what's happening here? Either the monkeys have died, which is bad. Either the monkeys have died, okay, which is what happens in cytopathic hypoxemia, etc. The body just cannot use the oxygen that I am delivering, and the body is dying. This is not a good situation. Or I just realized that there was a complete bypass because of some road work. And that bypass did not go through trees. In fact, it went through a different way. And therefore, the monkeys just could not get at the bananas, which is what happens with sepsis. You have a shunt, which shunts it would happen. So, what is happening here is that I am having a saturation of 100, but the body is not being able to use it. So, that's one thing. The other thing that can happen is I have a new worker, a new inexperienced worker who actually loaded my truck with 115 kg instead of 100. And the monkeys were all fine. The monkeys were all fine. They took their 25, but then I reached with 90. That means somebody is doing too much to increase the delivery of oxygen, and this increased weight will not only increase my fuel and operating cost, but also will break my truck more over time from wear and tear. And therefore, we have to say, hey, back off, back off. Whatever you are doing, maybe you're doing too much. We can relax. We can start decreasing our level of support because the patient is obviously recovering, and so on and so forth. Therefore, when we say, Dr. Sangwan, you are absolutely wrong because Rivers et al. Said that you have to have your venous saturation at 70 or so and so, and that did not was shown not to work, is because yes, one number cannot work for all human beings. You have to look at oxygen extraction ratio, because if my arterial saturation is 100 and then my venous saturation is 70, I'm extracting 30%. And if it goes down to 65, I'm getting worried. But if my oxygen saturation of my patient, despite everything, is 88% despite trying, then would I expect my venous oxygen to come back as 70%? That doesn't make any sense. Therefore, you start looking at oxygen extraction ratio, which is VO2 divided by DO2. So VO2 we know is cardiac output into 1.34 into hemoglobin multiplied by the difference between saturation of oxygen in the artery minus saturation of oxygen in the vein multiplied by 10. Then you divide all of that by cardiac output into 1.34 into hemoglobin into saturation of oxygen into 10. We cancel all of these, and therefore an oxygen extraction ratio would be saturation of oxygen in the artery minus your vein, which is pulmonary artery catheter or central venous line. There's a 5% difference, but hey, I want to know whether my oxygen extraction is increasing or decreasing, divided by saturation. So the venous difference in saturation divided by saturation. Why is the extraction ratio important? It is because, like I said, there's a limit to how much you can withdraw. The limit is 50%. And if my delivery of oxygen keeps decreasing, 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 there will be one point after which the body will not be able to extract more to be able to maintain the use of oxygen that it needs. And then the use of oxygen starts depending straight away on my DO2, and the patient starts dying, the lactate starts increasing, and so on and so forth. Again, we know that all of these are just to guide you. The lactate in sepsis increases because of many different things, including the fact that lactate is actually good fuel for the mitochondria in hypoxemic states. So let's not concentrate on any one number. Once I have made sure that the MAP is whatever I decided for that patient, 55, 60, 65, let's say 60. Once I have reached my goal MAP, I concentrate on delivery of oxygen. And once I think that I have optimized my delivery of oxygen, I look at the venous blood gas, specially drawn from a central vein. And if that venous blood gas shows a saturation or a saturation of 70% or a oxygen extraction ratio of 30% or less, I am happy, I have done good. If it shows an oxygen extraction ratio of 40% or 50%, I try to understand what can I do to make my delivery of oxygen more efficient and better for this patient. And here's an example. There's a patient whose saturation is 88% despite all my efforts with the ventilator. The SVO2 is 60%, which would be concerning, but then I look at the oxygen extraction ratio. 88 minus 60 divided by 88 is 31.8%. The patient has not reached the maximum possible, and it is still concerning, but not as concerning as this. So I never look at one number. So in the end, think in terms of DO2. If you want to be critical care, think in terms of DO2. Optimize DO2 for the patient. Rule number one, Hippocrates, DO2 no harm.